Hello, everyone. My name is Larry Shulman. I'm a medical oncologist from the University of Pennsylvania. I had been at Dana-Farber for many years, and I've worked with our colleagues in Rwanda now for more than a decade. Thank you very much for being here to listen to my talk. I'm very, very sorry that I'm not there in person. What I'd like to talk a little bit about is cancer survivorship. What happens to our patients who we treat, we cure of their disease, and they hopefully have a long life ahead of them. So I'm going to start with a few questions that I want you to keep in mind, and we're going to come back to these questions at the end of the talk. First of all, how can we design treatments that will minimize the early and late toxicities that our patients feel? And so when we think about survivorship, we need to think about it right from the very beginning when we're treating a patient, because it's those treatments that are going to affect their life long term. How should we best follow patients for toxicities and of their treatment? And so a lot of our patients, even with our best intent, will have toxicities that are long term. We'll talk a little bit about those, but we need to think about how we're going to follow them and take care of them. How can we best follow patients for their recurrence of their original cancer, which is always a worry? And then how can we best follow patients for the development of second cancers that are in fact caused by the treatments that we're giving them? We'll talk a little bit about all of these through the talk, and then at the end, we'll go back over these questions. So I'm an old guy, as you can see, and when we started treating cancer patients in the US around 50 years ago, we really only cared about getting rid of the cancer. That was really unique for us back then. We got rid of the cancer. We thought our job was done. But now we realize that the treatments that we give patients for their cancers can have short and long-term effects. And for our patients, survival is great, and it's obviously very important, but also the quality of their life is key. How are they going to spend the rest of their days? Are they going to have problems that are going to impede how they feel, or in fact make them feel quite poorly? So when thinking about our patients and long-term survival, we think about how to design treatments that will minimize the short and the long-term toxicities that they are subject to. We want to monitor the long-term toxicities to deal with them proactively. And we want to mitigate, have mitigation strategies for the long-term toxicities. How can we minimize them? How can we minimize the effects that these toxicities have on the quality of their life? So I wanted to use Hodgkin lymphoma, which is a common disease that we see in young people, as an example of the types of things that can happen to our patients. In the US, the median age for our patients with Hodgkin lymphoma are 26 years. So they're young people. They have many, many years of life ahead of them if we can, in fact, get rid of their lymphoma. In Rwanda, interestingly, it's almost 10 years younger. The average age of our patients with Hodgkin lymphoma in Rwanda is 17 years. So many of them are young pediatric patients. Our treatment usually involves chemotherapy, 4 drugs listed here: adriamycin, bleomycin, vinblastine, and dacarbazine. And in the US, we frequently use radiation for sites of large, bulky disease, often occurring in the chest. So they get chest radiation. We don't do that so much in Rwanda because the availability of radiation has been somewhat limited. But at some point, our patients in Rwanda will start to get radiation to the chest as well. In the US, when we used chemotherapy and we used the radiation, the likelihood of these patients being alive and free of disease 10 and 20 years and 30 years later is 85 to 90%. It's one of the first diseases we've treated successfully. My longest term survivor got radiation in 1968 and is still alive, but she has many of the complications that we see from radiation, and we'll talk about those. In Rwanda, we haven't done quite as well. 54% of our patients who have completed their chemotherapy at Butaro are alive and free of disease. Patients in Rwanda tend to come in with more advanced disease, which has a lower cure rate, but we're working on that, and hopefully at some point we'll get to the same survival statistics as we see in the US. So I'm going to talk to you about one of the patients, and this is a real patient who I originally saw in 1983 when she was 21 years old, and she had Hodgkin's that presented with disease mostly up in the chest and in the lymph nodes in the neck. And she was treated with having her spleen removed, which was a site of disease, getting 6 months of the ABVD chemotherapy I mentioned, and then getting radiation to the chest, what we call mantle radiation, and radiation to the lymph nodes in the upper abdomen. And she appeared to be cured. Her disease went away. And now, 40 years later, because it's 2023, that she still has no evidence of recurrence of her Hodgkin's lymphoma. But her story is complicated. And so 4 years later, in 1987, when she was 25 years old, she developed thyroid failure, which many of our patients do because the thyroid is in the radiation field. And she's on thyroid replacement, Synthroid. And so that's not that big a deal. It's a fixable problem just by giving her an oral medication. But a number of years later, 11 years after diagnosis, when she was now 32 years old, she developed breast cancer. And breast cancer is a very common disease in women who receive chest radiation before the age of 30. So she had a relatively small breast cancer. The lymph nodes were not involved. She had bilateral mastectomies, and she had 6 months of chemotherapy with cyclophosphamide, methotrexate, and 5-FU. And we seem to have cured her from that because in the years following, she's never had a recurrence of her breast cancer. But 12 years later, in 2006, when she was 44, she developed what looked like a desmoid tumor in the back. This was in the skin. It was a malignant tumor. It was surgically removed. And though we think we got all of the tumor and it's never recurred, because it was in a radiation field, the wounds heal. Even 23 years after radiation, the wounds heal very poorly. Then in 2009, when she was 47, she had a colonoscopy because we knew that she was increased risk for colon cancer, and she had 40 colon polyps removed. Now, this is 26 years after she received radiation to the abdomen. And the following year, she had an upper endoscopy and had pre-malignant cells in her esophagus or lower esophagus, just above the stomach. When she was 50 years old, in 2012, she developed coronary artery disease, which is quite common in patients who have chest radiation, tachyarrhythmias, intermittent complete heart block. She had a permanent pacemaker placed and had exertional dyspnea, and she developed aortic valve disease, aortic stenosis, and had an aortic valve replacement. Now, this is almost 30 years after her radiation. She's still, in my book, very young, only the age of 50. Many of our patients end up having aortic valve disease. Then 3 years later, she had her entire colon removed because of an increased number of pre-malignant colonic polyps. This is now 32 years after radiation. And then in 2017, when she was 55, she developed neck muscle weakness, kyphosis and weakening of the cervical and thoracic spine, again in the radiation field. And she's still alive, and she reminds me when she comes for follow-up that, in fact, she's still alive in spite of all of this. But obviously, the treatment that she had in 1983, 40 years ago, has had profound effects on her for the entire rest of her life. We now treat these patients differently, and hopefully our future patients will have fewer of these side effects. So what are the types of things that we see? So a patient like this, and many of our other cancer patients will have surgery. And depending on what organ is being operated on, they may have organ compromise. If they have kidney cancer and they take out one kidney, they're going to be left with compromised renal function. Likewise, if they take out a large portion of the colon or the stomach, they could have vascular compromise from the surgery and lymphatic compromise, so that when we take out a lot of axillary lymph nodes in breast cancer, the patient will often have lymphedema in the affected arm. They can have chronic wound healing issues, like our patient who I described, and chronic infections at the site of surgery because their immune system may be compromised because of chemotherapy or radiation. Now, I'm not going to go over all these drugs, but as you know, we use a lot of different types of chemotherapy and systemic therapies, and they have a variety of ill effects. So anthracyclines, which is something that our patient got, the Hodgkin's patients all get, has cardiac toxicity, as our patient did. We now have a drug called trastuzumab, which several of our breast cancer patients will receive, that also causes cardiac toxicity. We have the taxanes, paclitaxel, docetaxel, which cause neuropathy, often on a very protracted basis. And bleomycin, another drug in the ABVD regimen, can cause long-term lung toxicity, sometimes fatal, and so on and so forth. So all the drugs that we use have the potential not only to cause short-term toxicities like blood count suppression or nausea, vomiting, or diarrhea, but also long-term problems. And finally, radiation really can have profound effects, and those effects don't go away. They, in fact, get worse decade after decade after decade. And if you're treating very young patients who have many decades of life ahead of them, these problems can occur just like they did in the patient that I described. And so second cancers, breast cancer, thyroid cancer, GI cancers like stomach cancer and colon cancer, bladder cancer, leukemia, lung cancer, all can occur after radiation to a particular organ. Thyroid failure is something our patient had and occurs in a lot of the patients who have chest radiation. And vascular compromise. Radiation causes progressive atherosclerosis and scarring of arteries, whether it's the coronary arteries, the carotid arteries for patients who've got neck radiation, aortic valvular disease, as I mentioned, lymphatic obstruction. They can get pneumonitis or pulmonary fibrosis from the radiation. They can get musculoskeletal effects like our patient, in fact, did have with weakening of the spine over many years. They can get neuropathy. Fertility is a big issue for patients who get radiation to the pelvis, as is the case with some of our patients, may have compromised fertility. And those who get radiation to the brain because of brain metastases or other central nervous system involvement can have cognitive and intellectual effects, again, over many, many years. So these treatments are life-saving on the one hand, and we can't deny them because if they die immediately from their cancer, we haven't accomplished anything. But we need to also think about what the short and long-term complications are and try again to treat the patient maximally for cure, but minimally for long-term side effects. And just to reiterate, a woman like our patient who was radiated in the chest between the ages of 17 and 30 have the same likelihood of developing breast cancer as a woman who has a germline BRCA mutation, which we know is a high-risk marker for breast cancer, and over 80% of those will develop breast cancer in their lifetime. So radiation is a powerful carcinogen. It causes many of our patients to develop what we call secondary cancers. So as surveillance, we need to monitor patients for their primary cancer recurrence, in this case, Hodgkin's or breast cancer that she's recurred. We need to monitor patients for second cancers that might have been caused by her previous treatment. But we also have to remember that if you cure them from their first cancer, they're going to be at risk to develop the other cancers that patients do with aging, as in the general population. And we need to monitor them for organ dysfunction, whether it's vascular or cardiac disease, renal disease, liver disease, bone health, and so on. So all of those factors should be part of our survivorship care. So you don't just give the patient a hug and pat them on the back when you think that you've cured their cancer. You need to follow them in the long term to take care of all of these problems. So with that, I'm going to stop. Thank you very much for your attention, and I'm sure you'll have a good discussion there going forward. So thank you.